Okay, good morning. Thanks for coming. I assume more people will be coming, and they're probably sitting on the highway, which I would be doing if I wasn't giving this talk this morning. But I was asked to start with this slide, which is the MHIF highlights for 2017. I understand from Chris that we have over 165 manuscripts published so far this year. We have a number of studies that are in the top 5 for enrollment. We've done 10,000 plus hours of professional education. We have a number of studies coming up in the coming months. And I didn't put this in here, but our triathlon article continues to get a lot of media exposure. So this morning, I'm going to talk to you about our aortic dissection program over the 12 years. And I'm going to follow the format that Tim Henry used when he gave his update on level 1. So this isn't a board review type talk. It's more of a personal experience, what we've learned, and what we're working on. As far as the outline of the talk, whenever I give a talk on dissection, I think it's relevant to talk about how we measure the aorta and how we report the aorta, because I think that makes sense, because we encounter that much more frequently than we encounter an actual dissection. And then I'll go into the aortic dissection research that we've done either here at MHI with our local databases and through our collaboration with the IRAD group. I'm going to talk about the, whoops. I'm going to talk about some of the new approaches that we have here to treatment of aortic dissection, and then I'm going to spend most of the time talking about the design and the results of the MHI program. I'd like to start with talking about how important it is to recognize aortic enlargement. And both of these individuals were diagnosed with aortic enlargement. Fred Hoiberg, by virtue of very aggressive physical exams as part of his athletic career, was diagnosed with a bicuspid valve, aortic enlargement. And when it came time to take out some life insurance, the insurance examiner said time for another echo, and he ended up having surgery. He's actually had a second surgery, and he's now the coach of the Chicago Bulls. John Ritter, not so fortunate, he also had been diagnosed with aortic enlargement, but there was no follow-up of his CT scan that was one of these heart scans. And it wasn't until they were in the cath lab trying to figure out why he was having abdominal pain that they diagnosed his dissection. So his widow has actually made it part of her mission to help us understand and help emergency room physicians better recognize and treat aortic dissection. There's a great statement that came out on multimodality imaging a couple of years ago, and I think this is relevant for those of us that read echoes, as well as for our colleagues that read CTs and MRIs. So when we're talking about the aortic measurements, we should describe the aorta at reproducible landmarks perpendicular to the axis of blood flow, and it should be reported in a clear and concise format. We have techniques by MRI and CT, as well as by echo, which I'll talk about in the following slide. And whenever possible, we should describe the aorta as how it compares to the prior imaging. Our nurse practitioner group is working on guidelines for follow-up, and they've been asking me, how do we decide when we do follow-up imaging? And it really depends on how big the aorta is. But my usual algorithm when I see a patient with thoracic aortic enlargement is I do an echo. If it's diagnosed by CT, I do an echo to make sure there's not a bicuspid valve. I usually repeat imaging in 6 months. and then I do it annually. Once the aorta gets a little larger, and that is going to depend on the age and the gender of the patient, but then I may go to a 6-month interval. By echo, we should describe the aortic sinus. We should describe the ascending aortic size. And whenever we report the aortic size, we should describe the size of the aorta compared to other patients of similar age and gender. So I did it again. So this is the DEBAKEY nomogram we use in our echo lab, and there's similar nomograms for CT. So just for example, if you have a 75-year-old man and he has an aortic size of 4.3 centimeters, that's really not anything to be too concerned about. However, if the patient is a 25-year-old woman and she wants to get pregnant, it's a totally different story, right? So I think it's important when we describe the aorta to put it in that context. There's a number of genetic syndromes that we find when we look at thoracic aortic aneurysms. I adapted this from a review paper by Dr. Isselbacher from Mass General, and they broke it down into the syndromic aneurysms and the non-syndromic. So syndromic would be aneurysms that have physical features, other physical features besides the cardiovascular system. So the prototypical one, of course, is Marfan syndrome, Lowy-Dietz, Ehlers-Danlos, and then you have your non-syndromic aneurysms, most common of which, of course, is bicuspid valve, 1 to 2% of the population. But there's a number of other conditions, too, and familial thoracic aortic aneurysms and dissections. And about 20% of patients are going to have a family member that's going to have an aneurysm. So when we order the GeneDx testing, we do it a fair amount in our clinic. We test for 23 genes, and we're learning more about the significance of those genes. This is a study from our IRAD group looking at aortic size at the time of dissection. And if we think about the aortic size, indications for surgery, which are 55 millimeters or 5.5 centimeters, 60% of patients are going to dissect prior to reaching that size. So that's a little humbling, and if we think we can understand and predict who is going to have a dissection. I think we have a lot more to learn. This is from Tor Sant and Eric Isselbacher's group. The probability of having an aortic dissection or rupture within 5 years. And they broke it down, and you can see here the probability is actually pretty low, and it did not change for patients with a bicuspid valve. So some of you have been involved and are aware of a local athlete, a young hockey player that died of an aortic rupture. He'd actually had a number of physicals. His underlying condition was missed, and his family has undertaken local screening efforts to screen other athletes. So we had the opportunity a couple years ago to look at our sudden death in athletes registry at athletes that died of aortic disease. At the time we did this, we had 25 athletes, and we were able to look at the pre-participation data. We found data on 19 of them. 5 of the patients had been referred to cardiologists and were cleared to participate, and 14 weren't recognized despite the screening. Actually, 6 patients had been evaluated for chest or back pain shortly before the collapse, and 3 had been discharged from an emergency room in the 24 hours prior to their death. 11 of the patients ended up having Marfan syndrome or some features suggestive of Marfan syndrome. So we used that information, and I had the ability or the opportunity to work with my former colleagues, Dr. Braverman and Mirren, on this consensus statement on eligibility and disqualification recommendations for athletes. And there's a lot of information in this document on how we measure the aorta, how to index it, calculate Z-scores, when to do follow-up imaging, and importantly, which sports the athlete can participate in. For example, avoidance of isometric exercises and sports with the chance for bodily contact for athletes with some of these aortic conditions. I get asked a lot about this. surgical threshold. And it's been confusing because the guidelines have varied a little bit. But for the most part, for an ascending aortic aneurysm, what we know right now, most people are going to get surgery at about 5.5 centimeters. The AHA guidelines are pretty vague on these genetic syndromes, and they give you a very wide range, 4 to 5 centimeters. For the bicuspid valve, it's generally 5.5 centimeters, unless the patient needs an AVR, in which case you could consider it at 4.5 centimeters. And there's some interesting data coming out that maybe we don't need to do that, but yet having aortic enlargement and prior surgery is a risk for dissection. And certainly any patient that has symptoms of aortic expansion is a candidate for surgery. So this is my transition where I'm switching from talking about aortic aneurysms to aortic dissection. This is a patient who had both, presented with a type B dissection, but had a large ascending aortic aneurysm that we operated on first. I'm going to talk about our experience with the IRAD group. We've been part of the IRAD group since 2005, and it gives us the opportunity to share our data with these centers around the world and really allow us to answer important questions about how we recognize and treat aortic dissection. So I'm going to start with the case. This is a 61-year-old male. He arrived at 2 o'clock at one of our referring hospitals with 8 out of 10 chest pain. He had cardiovascular risk factors of hyperlipidemia, borderline blood pressure, tobacco abuse. He was hypertensive. A troponin was done, an EKG, and they were normal. He was admitted for rule-out MI. David, any thoughts? Any other tests you do, or are you comfortable with that approach? Pardon? The EKG was normal. They actually did right-sided and posterior leads as well. No chest X-ray was done. Would have been useful, right? So we do this all the time, though, right? We admit people. He was treated with Lovenox and Plavix, and then he suffered a cardiac arrest. We don't know the details, but he got CPR and dopamine and had a return of circulation. His doctor called our emergency room doctor, and they transferred him here. He arrived at 9 o'clock to 4100. Cardiologist on call saw him, ordered an echo. The echo was done in the cath lab at about between 9:45 and 10, and it showed an aortic dissection. So at that point, cardiac surgery was paged, and the patient was transferred over to the OR where he became hypotensive. The surgeon attempted a salvage operation, but there was uncontrolled bleeding, and the patient was unable to be resuscitated. I think we've all heard this term that the mortality for aortic dissection is 1% per hour. And if you look at it, that really comes from a 1950s article by Hurst that described the mortality for medical management, which is what they had at that point. So Craig Strauss and I had the opportunity to look at this in IRAD a couple of years ago, and we found that mortality with medical management for aortic dissection is still 1% per hour. This is Nick Wynn. He's a resident. He's worked very hard on this. You probably saw this at Grand Rounds earlier in the year when he presented this at ACC. But he went over to the Jesse Edwards lab and did one of these, almost like an old-time study where we looked at the autopsies of specimens that had been referred to the Jesse Edwards lab. And we found, well, this slide actually shows an intimal tear. So this is the cause of a dissection, a tear in the aorta just above the aortic valve. And this is an adventitial tear, which is the cause of death in most of these individuals. So 2/3 of these individuals were not diagnosed with dissection before their death, and that didn't change in the early years compared to the more recent years. Most of the tears were in the ascending aorta, and the cause of death was aortic rupture in the vast majority. So it's tough to be an emergency room doctor. Can you imagine seeing people all day with a variety of conditions, which may include chest pain, similar to the patient that I described, and trying to get the right diagnosis? So the first case that I remember of an aortic dissection was, I was a resident in an emergency room, and back in that day, there was no attending with you, and a patient came in with chest pain, and he happened to be a vascular surgeon, and he told me he was having an aortic dissection. So at that time, there was not any clear-cut testing that we would do with people. CT scanning was starting to be utilized. So I called the guy that became my echo mentor. He did a TE, found focal thickening of the wall of the aorta, and the decision was made to take the patient to the operating room. That was good enough for the cardiac surgeon. And indeed, he had what subsequently became known as an aortic intramural hematoma. So when we started this dissection program, one of our goals was to better understand the reasons for delay in diagnosis, and we looked at this in our IRAD registry, and we did this with Dr. Hirsch and Kim Eagle, Craig, and we found that the time from ER arrival to diagnosis was 4 hours on average in IRAD, and the time from diagnosis to the OR was an additional 4 hours, suggesting there's room for significant improvement. On this slide, I show some of the risk factors, and the presence of the risk factors is in yellow, and the absence is in green. So the patients that had the delay in diagnosis were female, they were older, they'd had prior surgery, they presented with atypical symptoms such as heart failure. In contrast, the patients that were diagnosed more quickly had pulse deficits, they were hypotensive, they had abrupt or severe chest pain. And Craig and I also had the opportunity to look at it in our own registry here at the subset of patients that presented here to Abbott. And we looked at the patients that had a late diagnosis. So we define that as 6 hours. So this was about 30% of our population had a late diagnosis. And we looked at the route that they went towards their diagnosis. So 23 of the patients were initially evaluated for acute coronary syndromes, similar to the patient I described earlier. 11 of the patients were treated for pulmonary embolism, and quite frequently would get a D-dimer or a CT scan, which led to the diagnosis. And 14 of the patients were treated for other. And a common theme on both this series and the larger IRAD series was that there were significant delays when the patient first presented to some of our outlying hospitals. This is a paper from our IRAD group looking at characteristics that are associated with dissection. So in the 2010 AHA guidelines, they want us to kind of focus in on the risk factors when we're seeing a patient with chest pain and looking for those high-risk conditions such as Marfan syndrome, aortic valve disease, prior cardiac surgery, high-risk pain such as abrupt onset of severe chest pain, and exam findings such as a pulse deficit or a diastolic murmur or shock or neurologic deficit. And 96% of patients have at least one of those features, if not more. And of the 4% that didn't have those features, half of them had an abnormal chest X-ray. So that would have been useful in that first case that I discussed, to have some screening tests that would lead you to the diagnosis. So we've been part of IRAD now for 12 years. A couple years ago, actually last year, this paper came out that looked at the 17-year trend. And over the time that IRAD's been in existence, CT scanning has become the most popular diagnostic test for the diagnosis, and endovascular approaches have become much more common. So this is, it's also interesting that the mortality for dissection in our IRAD centers has decreased over time, and there's a national trend in that direction as well. And it seems that high volume centers generally have better outcomes and high volume cardiac surgeons. I was given a talk to our fellows, and one of the fellows, who's now one of our staff, Luke Cole, said, well, what about this type 2 dissection? So type 2 dissection is not the same as a type B. Type 2 is a limited dissection that's limited to the ascending aorta, in contrast to a type 1, which is the dissection that goes all the way to the iliacs generally. So the type 2 have a little bit different profile than the type 1s. They have less mesenteric ischemia, less neurologic complications, peripheral complications. But it's interesting that when you look at their long-term survival, it appears to be about the same. One of the questions I get asked a lot is, what are the best medicines for aortic dissection? So on the left side of this figure, this is again another IRAD study looking at type A dissections. Use of beta blockers is associated with a significant improvement in survival in both A and B. For calcium channel blockers, no difference in survival for type A. There seemed to be a slight benefit in type B. However, in the GenTech registry, there was a signal of harm for genetic conditions treated with calcium channel blockers. So I think we have more to learn. This isn't by any way definitive, but it's a first step. As many of you know, I've been interested in this condition ever since that patient showed up in the emergency room. My first case, rather than an intimal flap, there's focal thickening of the wall of the aorta. And we had the opportunity to look at it. This was one of our first papers. This is Jamie Pelzel, who was really one of our outstanding cardiology fellows. He was back from the era where not too many Abbott residents wanted to do cardiology, but he and Tim Dirks paved the way for many of our subsequent fellows and now colleagues. So again, this is a focal intramural hematoma. And what we noticed in the literature at that time is that there were two different types of papers. There were papers that said how benign this entity was, and a lot of those papers seemed to be coming out of Asia, from Japan and Korea, in contrast to the European and the North American theories that said this is a serious condition that should be treated the same as a typical dissection. So the intramural hematoma was diagnosed more frequently in Japan and Korea, but generally in those countries was treated with medical therapy with a very low mortality, either medically or overall. So that was interesting. We had the opportunity to look at that in our IRAD group as well. This is the largest series published, to my knowledge, on intramural hematoma. We found that patients with this entity were older than the typical dissection. They had identical symptoms. They had less frequent AI and less frequent pulse deficits, but they had more frequent pericardial effusions, periaortic hematoma, but the mortality was exactly the same. So I think this data, though, gives us some equipoise as far as treatment. I'm going to give you two brief examples. Dr. Calcaterra and I shared a patient recently. I think she was 88. It was her 88th birthday, and she developed severe chest pain, functional patient from rural Minnesota. And Dr. Calcaterra and I had a discussion about the optimal treatment. I don't do the surgery. He does. He got to choose the treatment algorithm, and she got medical treatment, and she's done great. We got control of her blood pressure, and she's done very well. Similarly, Dr. Palouse and I had a patient that developed an intramural hematoma after a TAVR. And we looked at it, and we thought it was interesting, but she wasn't really a surgical candidate. That's why she had the TAVR. And we observed her, and really within a couple days, the intramural hematoma resolved. But I think for the vast majority of patients, they should be treated identical. So we've also been interested. It's in the guidelines that patients undergoing aortic surgery should have a TE. So we looked at this with one of our former fellows, Mark Thorsgaard, and we found that there was moderate to severe AI in about half of our type A dissections. We found that on the TE, there was about 2/3 of patients. There were some additional findings, and we found that the TE changed the management in 39%. So one of the ways it can change the management is the approach to the aortic valve. So the aortic insufficiency with the dissection could be related to pre-existing disease, such as a bicuspid valve, enlargement of the aorta. But in this case, it was related to this intimal flap. So the patient could be treated without replacing the valve in that specific situation. So this is work that Dr. Calcaterra has spearheaded. On the left side, you can see a normal aorta and the flow throughout the aorta. This is a patient that has a dissection. You can see the differential flow, higher velocity flow in a segment of the aorta, suggesting that that's an area of higher stress. And Dr. Calcaterra hopes with this model to be able to understand the optimal treatment. So this, in this cartoon, you can see the type B dissection, the false lumen, the shield with the stent graft. So the next couple cases are from Dr. Manunga, and they demonstrate some of the new techniques that we have available to us that we certainly didn't have in the beginning of this program. So we have an 88-year-old female. She lived independently. She went to the outside hospital with severe chest and abdominal pain, and she had a type B dissection. So she was transferred here with increasing abdominal pain. And for those of you that aren't used to looking at it, the white, the lighter, is the true lumen, and the lesser opacified is the false lumen. And you can see as you get into the abdomen, there's not a lot of flow in the true lumen. And that's a 3D rendering. And this is the video after treatment with a stent graft. Showing the aortic caliber throughout the abdomen is pretty much back to normal. And she's done very well with sequential follow-up. And how much follow-up do we have on her, Jesse? 1.5 years. Oh, and this is the 3D rendering of the aorta with the stent graft and the proximal descending. Compared on the right side to how she started. This is another case. I was not involved in this case, but Jesse was with Dr. Askew. 66-year-old patient presented to the AVID emergency room with severe chest and abdominal pain radiating to the back. Patient was hypotensive, had a creatinine of 4.7 and a lactate of 8.9. And there was a discussion at that time, what should be done? And the family really wanted something to be done, so they agreed to do an exploratory laparotomy as part of the surgery. And if the bowel was significantly ischemic, the plan was to back away. But the bowel was viable, and so a Bentall procedure was done, reimplantation of the coronaries. And then at the same time, this is the CT scan pre. A stent graft was placed. Any comments on this case, Jesse?
This gentleman came in with couldn't move both lower extremities, and then an abdominal pain, severe abdominal pain, and Judah and I both agreed that can't stop the lactate is way too high. Credit to his wife, still alive, still following. The wife is let's go back. So the way we proceeded, we did a laparotomy, looked at the bowel, cell salting, do that, open the chest, because I didn't want to put a wire down below. Then cannulated the left subclavian, which opened the chest. We actually got a wire from above because we're in the room and we could see it. That in 2 access. When you finished it, we were warming the patient because this was done in the hypothermic circle arrest. We did an IVIS to make sure that we did not need to check that. And the lumen distal to the subclavian was still failing. And we felt like we needed to get the patient.
So this is really great new technology we didn't have. Tim and I were talking earlier. When we started the program, we didn't have a lot of involvement of our vascular surgeons. We did not have these therapies, and it's been great. We have more things to offer, and I understand through this hybrid approach, we've done 13 cases so far, and 12 of the 13 have survived. And these were probably, a lot of those patients would not have been offered a surgery early on. So Dr. Manunga and the other vascular surgeons have worked on algorithms for treatment of type B dissections. And similarly, they want to be called with all of the type A patients as well and make a decision if they need to put a stent graft in at the time of the initial repair. And I remember when Dr. Pochettino came out and spoke to us years ago when he was in Pennsylvania, and he talked about doing that, and we were really not familiar, but this is something that we are doing now or assessing with every case. And this is a little bit out of sequence, but this is the protocol that we have for treatment of our type B dissections as far as who needs surgery. So higher risk patients are those that have larger entry points, the location of the entry point, the diameter of the aorta, the size of the false lumen, partial thrombosis. Those are some of the high risk markers. So why do we have an aortic dissection program? This is a condition that, as I've shown, has a very high mortality, 1% per hour. It resembles acute coronary syndromes, which are way more frequent. And as a result, the diagnosis of dissection is often delayed. There's not been a lot of people that are interested in this condition. And as I have shown, there really is a need for integrated approach and coordination between the specialties. So in 2005, a group of us got together and said, how can we improve the care for patients with dissection? And at this time, the Level 1 program had been started by Scott Sharkey and Tim and Barb Unger, who's here with us today, and Dave Larson. And that was actually going really well. And we decided to apply those same principles. And not everybody thought this was a great idea, but I'll tell you, two people that were very supportive were Alan Hirsch, who unfortunately passed away this past year, and Tim Henry. So these are the guys that said, sure, how can I help you do this? We had involvement of radiology, Dr. Einapudi in the beginning, Dr. Kapsner from the emergency room, Scott Streckenbach from cardiac anesthesia. We had all our surgeons, particularly Fraser Eels was very involved in the beginning, and he and I would travel to a lot of these outreach hospitals, usually independently, to give talks. Barb Unger, Barb, can you raise your hand? Barb was actually a nursing student here at one point, lived, what I understand, across the hall here as a nursing student, and has been a very important part of this. Spreading the word about dissection. And then Rob Tyberg is here. There he is. He followed Barb. And then Matt. I hope everybody knows Matt. So he is the current coordinator for the program, and he is available for any questions you may have. Mark Ebling, Beth Carnes, of course. And then there's been a research component, as I've demonstrated. Ross is here in the front row here, who's helped with the statistical analysis. The other people, and I'm sure these guys dread when I have my dissection clinics, and they have to read these images and compare the images because they know I'll be over there looking and trying to get a comparison. So they've been very helpful in the follow-up of these patients. So when our group first met in 2005, we said there's several things that need to be improved in the care of these patients. First of all is, why are there delays in the diagnosis? And I showed you some of the research we did to understand that. Some of the imaging was suboptimal. They would scan the belly, or they would, quite frequently, the imaging was incomplete. So we standardized the way we did that. Pharmacotherapy, I'll show you the data on that. There were delays in transfer. There were delays in surgery, in blood product use, intraoperative imaging, and certainly the follow-up was inconsistent. So I think everybody here is aware that the Level 1 heart attack program, which was started in 2002, has a network of over 40 hospitals. and is a standardized system for transfer of patients with ST elevation myocardial infarction, and it was modeled after a statewide trauma system, and it's really improved the outcomes and the time to treatment for patients that need a PCI. And Tim has shown this slide, but the mortality for an aortic dissection, if you present to Abbott Northwestern Hospital, if you present within 90 minutes or outside of 90 minutes, your outcome is really the same. So that's been important. So these same principles have now been extended to other emergency systems. Kevin Graham should have been on that earlier slide. He was the group leader when we started this, and this was his vision. Craig helped with this, and this is the figure from this circulation paper showing the interrelationship of these various emergency systems and how 20% of the patients in one of our emergency programs needs care from one of the other programs. So we have standardized protocols for each of these emergencies, and I think many of you are aware of the various entities that are treated by our emergency programs, and most of you probably have the app that these guidelines are on. So particularly with the aortic dissection, however, there's an emphasis for this multidisciplinary approach and close collaboration between cardiology, cardiac surgery, and vascular surgery, including that hybrid room. So when we started this program, a key part of it was education. So Barb probably went to all these places, right? And Fraser or I or other people traveled to all these sites. And we gave a number of talks about how to recognize a dissection and how to transfer the patient once the diagnosis was established. Furthermore, there was a feedback loop. So if a patient was transferred from one of these hospitals, Barb would circle back and in a very diplomatic way would highlight the areas that could have been improved in the care of these patients. And it worked out really well. I think in the last few years, I think we're giving more general emergency talks and not so much aortic specific talks anymore. But this slide shows where the patients are coming from. About 1/4 of the patients are walking in our emergency room here at Abbott. 24% are transferred from other line of hospitals, 6% from other hospital centers, and then the remaining 44% come from the outstate referring hospitals, the hospitals that send us the level 1 patients. And this is probably evolving as we've lost some of these northern communities such as Alexandria and Grand Rapids. This is our protocol. We have a protocol for suspected dissection, as you'll see on the subsequent slides, and then for confirmed dissection. So these, in this algorithm are the symptoms of aortic dissection and some of the features that should track the person to order the subsequent testing, which includes the CT scan with and without contrast, the manner in which the images are transferred, and then has checklists similar to the aviation industry for what drugs to give and who to contact and what the blood pressure goal. So if you think about an emergency room doctor in outstate Minnesota, they may see one dissection their entire career. And these checklists, I think, are very important for optimizing the care of these patients. We've gone through various algorithms as far as the way the patients get here. Currently, we're using the one-call transfer center, and they have algorithms for getting the right physicians on the case. For type A, we want the cardiac surgeon to be primarily involved with the vascular surgery and cardiologist, as well as for type B, the vascular surgeon and the cardiologist. The ER physicians should be included on the initial call or updated. Once the patient goes to the emergency room, and we want all the patients to land in the emergency room because we can order the massive transfusion protocols and while we're prepping the operating room. And if the patient needs further imaging, then the ER staff can monitor the patient. I remember before the protocol, going up to the floor where the hospitalist would take the call, medical students and residents were interviewing the patient, not the ideal way to take care of a dissection. So we also have forms that are useful as the electronic records don't interact with each other to get the pertinent data and remind the providers of what needs to be done. We have the order set. So we have order sets in Epic for suspected dissection, for the ER treatment, which is primarily the blood products, for management of type Bs, and when a patient is discharged. And as I mentioned, this is available for your phone. So when the diagnosis is established and the patient's going to the OR, this is the page that goes out. When the patient's going home, we want the patient to follow up with us. We want imaging prior to discharge. And generally, we try to see the patient at generally the 3 months to 6 months and then annually thereafter. And why do we do that? Well, patients that have dissection are at continued risk for expansion of their dissected aorta. They can develop large aneurysms. They can rupture. They can develop aneurysms elsewhere, and they can dissect elsewhere. So when we see the patients back, we do the annual imaging. We monitor their blood pressure and treat it with the appropriate medications. We recommend screening of their family members and genetic screening quite often, and discuss lifestyle and work restrictions. So this is the paper that we wrote, and this was published in 2010, and I'm going to give you some of the updated data. So we now have 300 patients that have come in, and I think this is these are the numbers to date. And usually you have 2/3 type A. So our patients are adhering to that. We have 200 type A's and 100 type B's. We follow 127 patients in our clinic. We know 104 to be dead, and keep in mind that this database started in 2003, and 69 patients have chosen not to follow or have followed up elsewhere. There's been an increase for the most part in the number of patients that we take care of over the years. So as far as some of those goals of the program, beta blocker use has, for eligible patients, has significantly increased. Beta blocker at time of discharge has significantly increased. So basically everybody is getting it. Almost everybody gets the intra-op TE. This is the initial data. I think everybody now with cardiac anesthesia is getting a transesophageal echo. So keep in mind the mortality is 1% per hour, and this is what we've done with time. So, and this is actually in minutes. So before the protocol, ER to confirm diagnosis, 255 minutes, 224 minutes from confirmed to the OR. After the protocol, we basically have cut that in half, and that change has persisted over all these years. So total time has been reduced by about 4 hours. And this slide just breaks it down for the outside hospitals and then the Abbott ER. Time was actually never really that bad in the Abbott ER, but we've made strides in both types. So as far as mortality, as I indicated, I think we're operating on some patients we didn't previously operate on. And this, I don't believe is the latest data because I think the trend is moving down. But we've made a significant strides in the mortality of our type A patients, and we've made strides in the mortality for our type B patients, 25% down to 14%, which is pretty consistent at the 1-year mark. So does follow-up make a difference? And this is data from that Amit Sharma did, looking at our database. Looked at the long-term survival based on compliance with follow-up. So the patients with the poorest adherence to follow-up are shown here. And when we looked at that statistically, lack of follow-up was associated with a poor outcome. I'm not sure how many other aortic centers there are now, but on this slide I list some of the other centers, and I know Barb and I have had many calls over the years. But on this slide I list some of the centers that have cited us in their description of their programs. Cleveland Clinic has written a couple papers about their program. Duke, Brigham and Women's, Mass General is interested in hearing more about our program. Tokyo, Liverpool, and so I think this idea is spreading. Kim Eagle, the founder of IRAD, said this: medicine based on memory is unreliable. Guidelines, when embedded in care systems, remind doctors and nurses of priorities, can improve the degree to which medical knowledge is directly applied to patient care, and patients ultimately get better care. So I'd like to thank all the people that have really helped with this, especially people like Barb and Matt that have done the day-to-day, people like Ross, who's done the statistical analysis, all of our colleagues, our surgical colleagues that have helped, and especially our new colleagues. So this is actually, I took this with my iPhone a couple of weeks ago. This is actually a sunrise, and I think Dr. Calcaterra and Dr. Manuga are two representatives here, and these guys are so fired up about it. They're so excited, and I used to feel like I was kind of pulling along, hey, we should do this, and now these guys are driving the effort and texting me on the weekends with ideas of things that we can do better. So I think we have a lot more that we can do with this program. So I have one more case I want to talk about. So in February of 2007, we have a patient who's actually here with us today, and her name is Patty Peterson. And she was followed by one of our colleagues with an aortic valve problem, and she is an entertainer. She's a singer, a radio show host, and a speaker. And she was driving down the highway and felt something wasn't right. I'll let her tell you that part of the story. But she knew to come to the emergency room, and she was diagnosed by Dr. Kearney, Warren Kearney, pretty quickly. And Patty has taken aortic dissection on as part of her mission to educate others, and she's been a great advocate for patients and spreading the word, and has actually teamed up with John Ritter's widow to help spread the word and educate people. And if you think about it, we've talked about what we can do to help educate providers and improve the transport time, but it's also important from the patient standpoint. How can we get the word out to the patients? And I always educate my patients, you know, if you have a symptom, you need to come in, and you are at risk, although it's very unlikely, you need to come in. So I think whatever we can do as patients to educate our patients is useful, and Patty would like to get a support group going for our survivors. Patty, do you want to say a couple words about your experience? Yeah, sure, come on up.
Good morning, everybody. These are not diva hours. Thank you for having me. Yes, this is a big thank you. Actually, did you post that on behalf of me? Because I want to say thank you to you and everybody here who's made this a mission in their lives. You know, my life was saved almost 11 years ago now. Can you believe that? Because of what happened in that emergency room and how quickly I was diagnosed, and although that wasn't the first thought, I was getting treated for a heart attack, there was that gut level intuition to check me for one more thing. That's what saved my life. But even prior to that, working with the cardiology team here at Abbott, I knew that I was probably a candidate for an aortic valve replacement. I wanted to stave it off into the future as far as possible, holistically took care of myself, exercised like crazy. But I also was having trouble once in a while with high blood pressure and especially irregular heartbeats. one night I drove myself to another hospital, and they sent me home and said, well, go just work with your doctor tomorrow. You know, your blood pressure's a little high, but, you know, go to your own doctor. I knew that night, February 12th, after 2 recording sessions of rehearsal, volunteering at my kids' school in junior high, doing a Pilates class, that when I felt that immediate burst in my chest while driving my car, something was terribly wrong. And I pulled over to the side of the road. Oh, good. There I am. I pulled over to the side of the road after that, and actually, I don't know if I need this even. If does it help? Yeah, okay. Well, anyway, when I did that, I called 911 because I knew I was in trouble. Everybody said, oh, you saved your life. No, I didn't. I was in trouble. Anybody would have done what I did. But when the ambulance came, it was really interesting because I called my husband and I said, listen, you got to meet me at the hospital. He said, are you sure it's not something you ate? Seriously, I mean, really, we put ourselves on the back burner? I went, no, it's not. But I knew that I needed to tell the ambulance drivers to take me to Abbott because my records were there. That was just trial and error to learn that under the umbrella of Alina, I knew that people would know what's been going on with me. Well, when I got there, and the gears were changed, and I got the CT scan, it confirmed the emergency room physician's suspicions, and that was aortic dissection. This has a mind of its own today. So, I should probably turn it off because it'll be feedback, you know. And those suspicions were confirmed by that CT scan, and he came to me, Dr. Kearney did, and put his 2 hands together, separated them, and said, this is what's happening with your aorta. And I'm like, okay, what's an aorta? You know, seriously, I didn't know what an aorta was. As it turns out, when that diagnosis happened, my husband said outside of my room, it was like a SWAT team had just been called in. Because there was a few people there, no. Now there was, because of that level 1 response, so many amazing people who came to my side to get me into that operating room quickly. I know that because of Barb's work, there were several adjustments that were made, and the only thing I remember personally is just to make sure once you get up there, the amount of blood plasmas, blood that you need, it was going to be 1 click, not 50. You know, things like that stick in your head about how you as a team work together to save a person like me, whether you realize it or not. Here I am, the patient, almost 11 years later, and I'm able to say thank you to you. Well, when I went in there, my family had gotten down to the hospital, and they pulled my husband and family into the elevator as I was going through the double doors into surgery. And I was feeling pretty good at that point, but they said to him, better call everyone you know because this doesn't look good. In other words, they didn't think I was going to survive. At that point, 45 minutes later, I'd lost a kidney. I was dissected to my legs, down my left arm, and up my right carotid artery. That's huge. I had no idea any of this was going on, so I was spared that. However, I learned about all of this later thanks to Dr. Harris, who's my cardiologist now, by him looking at subsequent echoes from the time I was in my late 20s for mitral valve prolapse. If that wasn't there, he wouldn't have been able to find out that I was a bicuspid aortic valve person. Who knew? As it turns out, when I met the team on that level 1 response, I met Dr. Hirsch, and then I met Dr. Ed Johnson. And he said, listen, I'd like to answer a bunch of questions for you, but we got to get you into surgery. And I promise to come out and hear you sing after this is all done. And I went, well, you don't have to wait to hear me sing. And I went into, somewhere over the rainbow, way up high, there's a land that I've dreamed of once in a lullaby. Well, the nurses pulling me from the CT scan imaging, and I'm singing, are crying. I'm going, I have no idea what's going on here, but goodness knows they were going to fix me, and I was going to be right back. This was my mindset going into this, not, oh my gosh. I was going to get fixed. I'd be right back. Well, about 7 hours later, luckily for me, that was the truth. I do have a a St. Jude valve, and I support them, and even went to the FDA to talk about life with an aortic valve. That was an interesting trip last summer. But even though it took a long time to get used to the kick drum in my chest, through medication, through beta blockers, through addressing the adrenal gland problem that I have with hypokalemia, I really am, I say that you watch me like a hawk, all of you, and I live my life. I'm a very busy singer. I sing powerfully. I think I make my doctors wince when they're listening to me. And you know what I say? I say everybody should get a heart valve. I can hold a note like you can't believe. Seriously. But I always remind people to take care of the heart health. This is different. Teaming up with Amy Yazbek, who was the widow of John Ritter, we created Ritter's rules. She did. And the genetic testing component to it has become more and more important because of it running in families. So I'm sure that we're probably running out of time. I could talk forever personally, and what I've experienced. I've loved talking to IRAD and some of the aortic symposiums as a patient from a correct diagnosis, as opposed to Amy, who her husband didn't have a correct diagnosis, and it wasn't told to him. If I would just say that, it wasn't told to him when that imaging came back. It may have been in the reports. He was never informed that he had an enlarged aorta. Nor was I. And so I think that in 10, 11 years, there's a lot of things that have changed. I know, for example, for me, I had an echo in January of 2007. I dissected the next month. My aorta was at 4.3. The graft, when I study my stuff, says it's at 4.6. So when there's a pre-existing condition like I have, one that could run in a family, the importance of making sure the family gets checked is what I tell people who have either been diagnosed or who have lost a family member through this aortic disease family of conditions. So that's kind of my mission. I backed off for a little while my mother was in the final years of her life, but I'm really grateful to be back here on this stage singing to you. And just being able to say thank you so much for all you're doing. Don't stop. Keep believing in what you're believing in, because you're truly saving people's lives. Thank you.
All right. Thanks a lot, Patty. I think we're almost out of time. Patty actually has a number, just to show you how active she is. She's got a number of concerts. I get these email blasts of her shows at the Dakota and other places. Hard to keep up with all the stuff that she's doing to raise awareness. I think we're essentially out of time. Is there any burning questions? Be happy to answer any other questions. Thanks for all your help.